Now let's meet our Q&A panelists. At today's panel discussion, we have Professor Nicholas Hart, Professor Joao Winck, Professor Annalisa Carlucci, and Professor Amanda Piper with us. Professor Hart is the director of the Lane Fox Respiratory Service at Guy's and St. Thomas. He is a professor of respiratory and critical care medicine, King's College, London, UK. Professor Winck is a consultant at the Northern Rehabilitation Centre and an associate professor at Porto University, Portugal. He's the current chair of NIV Support Group, ERS. Professor Carlucci is a consultant at the Respiratory Rehab Center in Pavia. She is the manager of NIV service for chronic respiratory disease and sleep disorders therapy. She's an associate professor at the University of Insubria, Italy. Professor Piper is the manager of NIV service, Royal Prince Alfred Hospital, Sydney, Australia. She is an associate professor at the Central Clinical School, Faculty of Medicine, Sydney University. I would like to turn the presentation over to our chairperson, Professor Chen Rongqiang.
Now it's time to open for the question and answers, and we have the penalties, and would like to share some experience or opinion.
So this is Nick Hart from the UK. I would just like to thank everybody. We are very much at the start of this, and we're probably 20 days behind Stefano's experience in Italy. We've currently got 10 patients who are confirmed, with 6 more pending who are intubated, ventilated on invasive mechanical ventilation or on ECMO. And Stefano, your comment about the epidemiological change, we are seeing category 2. We have patients between 40 and 50 years of age who come in with a minimal oxygen requirement and then rapidly deteriorate. And in fact, with our process, and you have to do the process within your own hospital, we've now got a MERIT team, which is a mobile endotracheal intubation response, rapid intubation response team. And this team is actually, we've set up as mobile and fixed to ensure that patients can be supported as quickly as possible. But can I just say thank you to everybody on this call, because it has been incredibly enlightening for us as we start to move forward with this problem.
Yeah, thanks for Professor Hart and the comment, and both Professor Lava and Professor Hart mentioned the different phenotype of the patients, and some are progress slowly and some are rapid change in a few hours. So there's also some report in the they try to differentiate the difference between these the 2 phenotypes, and any comment from the Professor Pan? You are still working in Wuhan, and do you think there's two different phenotypes and some change rapidly in a short time?
Many patients at the before there is not well, but yes, but tomorrow patient is the PF is become very serious and should be intubation immediately.
So any comment from the experts from the panel?
I have just a question, a technical question for all of you, because actually what we see is that all the schema, all the flow chart can stop here, because actually to evaluate the effect of non-invasive ventilation after 1 or 2 hours and decide to intubate the patient is what we cannot do, because we don't have ICU beds. So what is your opinion about the use of a high flow nasal cannula? Because in many parts of Lombardies, actually they considered this kind of technique as contraindicated because of the droplets dispersion.
I will take this question first, and then I would like to have a comment from other specialists. Actually, there's some report showing the air travel distance with the nasal cannula and or with long invasive ventilations, that exotic gas travel longer distance than normal breathing, but it's only the distance. Low evidence showing with the use of this high flow oxygen or NIV can increase the shedding of the virus or increase the risk of the medical staff. I performed NIV for many patients during the SARS outbreak, but not this time. For SARS outbreak, I myself performed a lot. In case it's well protected, in a room with good room ventilations, I don't think there's anyone can. So I think intubation procedure, majority during the SARS outbreak, our institute have 26 of my cohort got infected. Majority of them are infected due to intubation procedures, not related to use of NIV. So from my viewpoint, and I see evidence showing NIV increase the air travel distance of expired gas, but low evidence showing more virus going out of the lung or medical staff using NIV have high propensity of infections. So any comment from the other experts of the panel?
Now, if you look at the literature, there is one paper in the ERJ showing that with high flow nasal cannula is not expanding the droplet so much. Like the range is within 30 and 40 centimeters. It's like a normal oxygen, more or less. The problem why people, they don't use high flow is because it does not work. I heard experience from my colleague up in Lombardia, and they all tell me that it's not working. And we try in 2 or 3 patients, and it does not work. Don't ask me exactly the reason why, but why it's working well in other de novo respiratory failure, in this pandemics, it seems not to work fine. I don't know if it's a matter of PEEP that cannot overpass 4 or 5 centimeters of water. I don't know the reason, but when sometimes CPAP works, high flow does not. And I remind to you that CPAPs and high flow are totally different physiological mechanisms. What do you think, Nick, in theory?
Yeah, so Stefano, we are not using any high flow, and the problem with high flow is we've identified there could be an infection risk, and up to 60 liters per minute, it goes up to about 0.8 meters based on the data. The concern I have is the amount of oxygen we have in the hospital. So we have had to calculate how many, so Stefano, you know the message I sent you the other day, I've been charged in my hospital to create 300 invasively mechanically ventilated beds. Now, some of those will have non-invasive ventilation, but we've had to calculate how much oxygen we will require to run these ventilators. So I'm working with the engineers, and luckily enough, it's pressure, flow, and resistance. So we all know what they do. So we're working with our engineers, walking around the hospital, making plans. So hearing all this from our Chinese colleagues, our Italian colleagues, for me, I know we've got some very, very tough times ahead, but it allows us to prepare even more. So thank you.
Look, I would echo that from Australia. We're at the very, very early stages. So we've only had 3 deaths, and they've been the elderly at the moment. But we have a big problem. Our intensivists who are really running with this have really put, at least in our area health service, have really put a blanket over using non-invasive ventilation or high flow. Everything has to be in intensive care at the moment. So it's very interesting to hear from you guys. In particular, I was interested in the health, because I think one of their concerns was the healthcare workers becoming infected. And yet it seems from at least the Chinese experience, that's not really a huge concern, so long as the healthcare workers are very well, the PPE is very well set up and staff themselves are looking after themselves. I am interested to see that it seems very different in both Italy and the UK, that high flow nasal prongs won't be being used. So that was definitely something we weren't going to use. Can I ask Nick, and it seems like, Professor Nava, you've really explained very nicely how you're doing things in Italy. In the UK, what sorts of ventilators? You've got 300 ventilator beds you have to find. What sorts of range of ventilators are you going to be using in the UK?
So currently, and I got off a call today about ordering more ventilators, which I'm sure everybody on this call has been through. So our standard ICU ventilator is a Draeger V500. So that's just our standard ICU ventilator, but we're extending our ventilators. And in fact, NHS England have purchased a bulk order. So that's obviously our control and command situation, that they have actually purchased. They put an order in for 5,000 ventilators from ventilator companies across the world. So I've got a list of those from the GE, R860. There is some Oxylogs, there's in transport ventilators, there's other types of ventilators, but the NHS is really driving, the NHS England as part of control and command is driving that for us.
Right, okay.
With our advice.
Right, okay. But Professor Nava, you in Italy, in your centres, if necessary, will be using the more simplified ventilators as well, basically using whatever you've got available to you? Yeah. Okay.
I mean, we use everything, even tuna can, if it's working.
Okay.
Really, I can't believe it. I mean, we took off the closet some ventilators we were not using in ages. I mean, we order as well in our region 2,000 new ventilators. I mean, and it's a mess because we do not know exactly when this wave is not going to finish. I think, to be honest, I know the therapy. The therapy is stay home. This is the only therapy that we can apply so far. If people follow the rules, we can stop this. If people do not follow the rules, we're going to be stuck. And I have to say 2 things about this. We as Italian, we don't like to follow the rules. So we did a huge mess in the last couple of weeks, especially because politicians, not to bankrupt the country, they said, well, this is not as bad as we can solve the people as we could, as we thought, so the people were going out and blah, blah, blah. And I was surprised even more that all the other European countries, learning our mistakes, they did not stop anything. I mean, I was surprised that France, Germany, Portugal, everyone stopped school now. They should have stopped 2 weeks before, not now. What do you think, Joao? What are the feeling in Portugal? That it looks far away for us. I mean, it's sort of paradise. I mean, he said, oh, if I were in Portugal.
So first of all, let me thank all the speakers for outstanding information for us. And as Australia, we are just at the beginning. I think we have almost the same numbers as Australia, around 100s, India 100s, and still no patient critically ill, which is kind of surprising for me. But as you said, Stefano, our politicians have agreed to make these shutdown, as you Chinese people have told us. And as for this weekend onwards, everything will be closed. So all the politician councils, all the public places, restaurants, everything, houses, and everybody's saying like io sono a casa, we are at home. Everybody's saying that, and hopefully that will not change. But we will have to order, like Nick was saying, some ventilators, and we are just struggling a little bit to get them. I know that here in Porto, our mayor has a good connection in Shenzhen with the mayor of Shenzhen in China, and he was saying that he could order like 1,000 if it was needed. So I think here the local and the government is also taking care of this issue about the scarcity of ventilators that you guys in Italy are having, and hopefully we will have them ready for the big bang, because that's what has not happened yet. But actually, I had to ask you, all of you, because what I've not seen here, and as well in other countries, is why our chronic respiratory failure patients are not getting inside the hospitals with exacerbations. As far as I knew from all the series published in China, published also in Hong Kong, I don't see patients with chronic respiratory failure like we had in H1N1, and you probably remember Amanda and you, Nick, the amount of patients that got exacerbated during the H1N1. I wonder if you have any explanation for this. And the obese, the severely obese, I've seen one case that was obese, but still we see more cardiac patient and diabetes. Is there any reason for that? Any guys,
Yeah. Any comment from the Beijing or Wuhan?
Yeah, I try to answer the question. Yeah, based on our admitted patient, the high risk of the severe patient mostly suffering from high pressure, diabetes, and obesity. All of these factors are risk factors.
Okay, and some data from China, they're showing that based on the literature, around 3% of the COVID-19 cases have the background of COPD. So we did have some COPD background, and they have COVID-19 infections. And in these cases, the severity and mortality is much higher than those without COPD. Around now, based on the literature, it's around 3% of COVID patients have COPD background.
If I may add one thing, we see more than COPD patients with pulmonary fibrosis infected by COVID-19. Actually, we were half of our team was put in quarantine because it was not easy. On the first specimen was negative, and the CT scan was not typical because of usual interstitial pneumonia. So, we decreased a little bit the level of attention, and as I said, half of the team went on quarantine. But I found more interstitial diseases related to COVID than COPD. But I mean, this is totally anecdotal. But please, especially for Nick and Joao, and also Amanda, clearly, be careful. in patients with chronic respiratory disorder, because the CT scan is not always as clear in patients without any pulmonary disease. Because, you know, we do CT scan in every guy with respiratory failure or a fever now, because it's the best way to discriminate. Rather than the positive or negative specimen, because we know that 30% of a specimen can be negative with a positive pressure. So we use a lot of CT scan, but please be careful in patients with a pre-existing pulmonary chronic disease.
Professor Nava, you were talking about that in Italy you weren't finding that the high flow nasal cannula was terribly effective. Can I also ask the people from China using CPAP, and then if that fails, going on to NIV? Are you just delaying going on to NIV straight away? Is there actually a place for CPAP, or should we just go straight to NIV?
To my experience, on the first, usually use CPAP for the patient good compliance for using NIV. But after the patient have a good compliance for NIV, we then change to BiPAP for most patients. CPAP most used in the early age of NIV treatment, just only.
From my knowledge, I don't know there's any comparison study to showing the mode of CPAP or BiPAP, which is superior. We initiate with CPAP because we believe CPAP, the compliance to CPAP is better than BiPAP. And as for, we insist these should be used continuous for days or even weeks. So with the continuous use and without proper monitoring of the patient, you have low one-by-one care of the patients. So very often the patient use it in their own ward, room, without proper care. So CPAP, and in case of leakage, there's no interfering with the synchronization between the patient and ventilators. But BiPAP, in case this synchrony will increase the short of breath, that's the consideration for that. And once the CPAP is failed to improve, we'll try to switch to BiPAP. Or even for more severe cases, we initiate with BiPAP. But for the relatively mild one, and we will try CPAP first. We use a lot of CPAP for SARS patients, and we'll use it for, say, a week or even longer. And that's the only thinking, not evidence for that.
What we saw was that actually these people needs very high HIPAP value, CPAP value, 10, 12, even higher. This is very important, and perhaps this is the reason why the helmet is the best choice, the first choice to approach them. Very high CPAP value.
Oh, can I just make a comment? And this is for Joao and for Amanda. We are seeing phenotype B, or whatever Stefano said was the second wave. We are not getting the opportunity. People are on 2 liters of oxygen, 3 liters, and then they have rapid oxygen requirement increase from requiring intubation. We're not having the opportunity even to think of any non-invasive ventilatory support currently based on our cohort that we're seeing. So I think that's really key, and that observation from Stefano I've shared already with my clinical colleagues in my institution, and so that's very helpful for us.
Yeah, it is. Thank you. Yeah.
I have so many questions to you all, my God, but I'm not sure if I can do this. The case that I think it was Professor Chen about this prone position and NIV and secretion clearance. I mean, that's really fantastic thing. And I wonder if you, Stefano and Annalisa, in your experience, you are also seeing some patients that are on NIV that could benefit from this prone positioning and also secretion clearance, you know, just to make sure we can improve oxygenation, because I think that's this COVID-19 has a particular involvement of the terminal bronchioli, and there is some secretion and some mucus that I've seen in one webinar before that is kind of a very sticky and whitish jelly kind of mucus. And so I wonder if you think that complementary to NIV in some cases, and even the ones that are not candidates or there is no ventilator, invasive ventilator available, if we could also you know, do some prone positioning and some secretion clearance. And I mean, what about the concerns about secretion clearance? So this is kind of a hot topic, right?
I don't have any experience about prone positioning during non-invasive ventilation, actually. And we don't use some techniques to improve clearance of secretion because of the problem of the droplets now. So I don't have experience about this.
If I may, Annalisa, I would say 3 very fast things. We forgot to say that this patient requires, when intubated, long period of mechanical ventilation. This is a problem because they occupy the beds for 2-3 weeks. So this is the first thing to keep in mind, Joao. They are ventilated for more than 2 weeks, first. Second, I agree with Annalisa. I don't know if anyone tried the prone position, but it's going to be probably extremely difficult. I don't know. I never tried. We do not in our unit for a simple reason, because we don't have the personnel that is able to do that. So all the patient needing position, they go to Marco Ranieri's, for example, ICU, where they prone, and they are doing quite well. But I agree with Annalisa. In all the patients I saw, there was not a single case of secretion. So I think this was overestimated. Maybe the Italians are different phenotypes, but this is totally not seen, at least in my patient.
Stefano, that is really helpful, even though you have just disappeared. You just said a really key point, that 1 in 3 of the RT-PCR tests you do are negative, and then you said something about positive pressure. Can you explain that and expand on that?
You know that 1 out of 3, maybe a little bit less, are positive, are at the end of the day negative. Sorry, they should be to negative. Anyhow, we do, by protocol in our hospital, all the patients coming with a suspect of COVID-19, like us with fever, as you know, cough, etc., they undergo a CT scan. And then we put them, if the CT scan is suggestive of the COVID infection, we put in what we call a suspicious patient ward. It's a sort of orange wings of the hospital, where we keep patient for 24 hours, the time needed to get the result. So if the CT scan is negative, but the specimen is positive, they go on the red track. If the CT scan is negative and the specimen is positive, they as well go to the red track. If CT scan is negative and the specimen is negative, they can either they go home or they are admitted to. We got what we call clean and dirty wings of the hospital. Clean means that patients with COVID, they're not allowed to go. Dirty, that means there are only wings for COVID patients. But you should be aware of this. You should not mix dirty patient with clean patient, because otherwise it's going to be a mess. So you need to divide them since the beginning.
Well, the experience in China is quite similar with Professor Lava's story. And the PCR positive rate is around 40%. In case you have a typical presentation of CT scanning, combined with the epidemiological data, and should be careful about that. So in case you repeat it, and in case you have the lower airway specimens will show up positive later on. So this is very serious things.
If I could go to Professor Span case, I think that case is really important, and I think that both you, Stefano, Annalisa, and Nick that work in weaning centers. So we have seen that these patients take a long time in the ventilator. Some of them are tracheostomized, as Professor Pan's case. And so I wonder about the shedding of the virus, and how safe is this to take care of these patients in weaning centers. So I wonder if you have thought about this, because some of these patients will end up being tracheostomized and being on long term. I think it's probably a small proportion. I think maybe like 1 or 2%. I don't know. I have not seen any publication, but do you think that these patients will have some, will increase the pressure also to the weaning centers?
May I have a comment, and then maybe from later on from Prof. Han? In Wuhan, actually more than 3,000 medical care workers infected, and more is around 1,700 was confirmed, and supposed more than 3,000. But in Guangdong province, no single one at the moment. And maybe Dr. Sarah can have a comment from Beijing. So, the prevention procedure is very, very important for that.
Yeah.
And second, then for the recovery phases, we only allow the patient go home with at least 2 times of negative testing. And now there's some center they test the antibodies in case they have a very strong antibody inside about the circulation, and the specimen from the airway is negative. And then I think, and for weaning is we have 6 activated patients, and they're actually, and it's like ARDS patients. We very often we use the NIV to step down because weakness of the muscles, and coming from Beijing and the prevention of.
Yes, I agree to Professor Chen's opinion. That in Beijing, for discharged patient, at least received 2 times PCR tester over 24 hours. If the 2 times both negative, is a criteria for one of the criteria of discharge. For weaning protocol, especially for ICU weakness patients, I think that based on our experience treating HENE, influenza, and other severe patients, for our team, we have also 2 very severe COVID patients who receiving ECMO treatment for over 20 days. For the 2 patients, it is very also faced difficulty for weaning protocol. Well, I think for this difficulty for weaning this patient, in personal evaluating is very important. For our team, we use ultrasound, the EIT, and other techniques to evaluate this patient. If the patient face master weaning protocol, such as have a strong spontaneous strength, and the FiO2 below 40%, and the PSV level below 15 centimeter, and the PEEP below 6, we think that the patient meets the winning window. So mostly we use invasive to non-invasive or invasive to high flow nasal cannula for this patient to perform weaning protocol. After patient receiving non-invasive or high flow nasal cannula oxygen, during the first 2 to 5 days, closely monitoring for this patient is very important. For our team, invasive ventilator patient, 8 invasive ventilator patient in Beijing in our hospital, and we also attending the China military hospital severe patient diagnosis and treatment. There are also about over 10 invasive patients, very severe for some hospitals. During this patient, about 3 patients who also receiving ECMO treatment for over 20 days. Is a very difficult.
Can I make a comment, and thank you for that excellent description of the weaning process in extubating onto non-invasive ventilation. Do you, and appreciating that the RT-PCR test has its limitations, do you wait until the patients are negative, or do you just proceed and obviously continue with the usual PPE protection?
In China, the policy is you have to do the PCR testing before you determine can be go home, the patient allowed to go. Yeah,
home. When you're going to extubate them, do you wait till they're PCR negative?
No, majority of them at that time is already negative.
Okay.
The specimen is very important. The low respiratory tract specimen is preferred. In the early age of China, throat swab, the positive rate is low. So take the lower respiratory tract sputum is very important for diagnose the safety. Yeah.
Yeah. Lower airway secretion for PCR is more reliable.
Mm-hmm. So that's what we're doing. We're doing protective bronchoalveolar lavage.
Yeah. That should be a much better specimen.
Yeah.
Very good. And guys, can I just, well, one, I want to say thanks to Philips for bringing it together, but can I just say it's amazing that we were all together on the 8th of January in China, and this was just then starting within China, and where we are now and where you guys have been through, and you as well, Stefano and Annalisa, and all the data you provided with us. Thank you. Sorry, Stefano.
No, we were in Berlin together. Yeah.
Well, before that, I was in China as well with the guys on this call. Just we were chatting about non-invasive ventilation and COPD, Stefano, because why wouldn't we? Now our lives are changed.
Yeah, you're right, Nick. Totally changed. Yeah.
One question to you guys about a CPAP valve with a filter. I don't tell you the brand, maybe you know, because I don't have any conflict of interest, but anyhow, in times of scarcity of ventilators, do you think that could be of value? You know, this CPAP valve that you have to connect only to oxygen source and as a specific HEPA filter. Do you think that could be a good choice?
I mean, as I said, we use mainly outside the unit CPAP, helmet CPAP, or only for safety reasons, with 2 filters here. I don't have any experience with the CPAP you mentioned, because for safety reason we decide to limit the use of a face or a nasal mask. This was a choice. I mean, good or bad. You need to make a choice, you know, Joao. So at that point in time, all the guidelines are not taken into consideration. So maybe, but I'm not sure. At one point in time, as I told you, you need to ventilate patients with whatever you have. I hope you're not going to face what China and what we face right now, but You know, today Annalisa phoned me because one of the father of our colleagues, 70 something, could not receive intubation, for example. Then, yeah, I mean, even it deserves. So, I mean, we managed to do it, but you know, it's something that we only talk. We talk a lot about end of life decision, and we talk right on the paper and so forth. But then when you face it, it's a totally different issue, believe me. But even if it is a 92 years old lady, it's difficult to say no.
We actually, Joao, we use the helmet with the oxygen source. There are two types of it. One of it with the Venturi kit that is not detachable from the helmet. In this case, you need to avoid the droplets dispersion there, so you can use it only at 100% of FiO2. You exclude the Venturi setting. So you need an oxygen flow that is need to be more than 45 liters per minute. So you need the double oxygen fluximeter. You have another system where the Venturi kit is detachable, so you can put the filter between the helmet and the Venturi, and you can use it at different kind of FiO2.
Thanks a lot.
And you've just raised a really important point there, Annalise, about the amount of oxygen consumption, which we're all going to be, well, within our hospitals, we're going to look to be limited by as we increase to super surge capacity.
I have one more question about the PPEs, because here in Portugal, and I guess that in other countries in Europe, are facing scarcity of PPEs. And I've seen that in the UK, guys, you have been more practical, considering the PPEs of, you know, a community or GP setting versus an hospital setting. And also concerning, you know, the healthcare workers that have been in contact with some positive cases that are allowed to go to work. And so this is kind of a very complex situation here, and a lot of discussions going around. I wonder if you, Nick, could expand a little bit on this, because this is really an European situation. So the scarcity of PPEs, and you know, the rules for protection of the healthcare workers and all that. Could you tell us a little bit more on the UK, you know, scenario right now?
So, as regard PPE in the UK, we have clear guidance, and that clear guidance has come from Public Health England. So Public Health England have issued suspected and confirmed cases of what we should be wearing. Now, when we started with this, we would double layer PPE with hoods, and double mask and clogs, and the way you see it on a lot of photographs. However, that was not necessary for protecting us. That was to reduce the risk of contamination of the environment. We were part of a high consequence infectious disease unit. So when we got our first sick patients, we were absolutely, again, just to highlight, control and command. We had clamped down on all the activity around, and so we were containing the patients. Obviously, when you breach through containment, then we knew we'd change the PPE because we'd run out. So we use, now for confirmed COVID-19 cases, we use, like everybody, we're using long sleeve gowns, we're using double layer glove protection, we're using an FFP3 mask, we're using a visor, and that's the protection. And then we're going through simulations of donning and doffing PPE. So there is a whole program of education that we've had to roll out around this, which has been exceptionally well received, but still people are anxious in our units where they're working, and there's no doubt about that. Going on to what we did in the NHS for a containment phase, we actually had people at the beginning who were poorly, who were unwell or weren't unwell, and we would go to see them in their homes, as in there would be people going out wearing PPE into their homes, taking swabs, isolating them and making sure they didn't move. If it was positive, when it first started, and this sounds kind of strange, we did have well folk in our hospitals in isolation who almost went stir crazy. But we had this, again, this control and command attitude to making sure we reduced infection spread. If you look at the time for the UK to hit 500 cases, compared to Italy, France and Spain, we were actually 20 days behind. It took us 40 days from the 31st of January to just this week, actually on the 13th of March, to breach through 500 cases. So we know that really worked. However, we're now in delay phase, and that's why we're taking the opportunity to adopt a different strategy, and that's really just that containment or delay.
Thanks for all the panel's experts and sharing the experience and their consideration in dealing with COVID-19 patients, and especially in the use of ventilator support. I will have a brief summary. We should prepare for the pandemic, and there's some different phenotype and some rapid progressing cases, and we have to understand why they change. And there's a discussion in China for this phenotype, and we try to limit any activity taking efforts. I myself did have experience at a patient demanding oxygen, but quite well, but went to the toilet because the constipations, he used efforts, and after that, severe desaturation and then intubated. So the opinion from Chinese experts that the discussion on this try to avoid any demand for increased ventilatory demand and efforts, but we need more understanding of this phenotype. And for the concern of the transmission and infection of staff, I think majority of us agree we should prepare ourselves, and prevention strategy and equipment is important. And some areas like China at the early stage, shortage of medical staff, medical facility equipment is very challenging situations, but we should prepare for that. For the selection of the ventilatory support, and seems majority of the experts agree, high flow nasal cannula is not helpful. We should initiate non-invasive ventilation, including CPAP or BiPAP, and suppose the pressure, and both the pressure and the oxygen are important for the patients, and we cherish, appreciate that the experience from Beijing with prone position for patients receiving NIV, and the experience from the Wuhan, Dorpanshire, very challenging cases will progress and demanding invasive ventilation and with the oxygen. The oxygenation function is declining rapidly, and also we share the same experience with Professor Lava in Italy. We should prepare for everything and make some decision on the medical service we can provide and the demand of the patients. I think then we can have so many input from the Professor Hart, the preparation in UK, and I think all these I think that is beneficial for preparation and care of the patient with COVID-19. So thanks for organizing such a wonderful meeting, and this expert from different areas sharing their expertise together, and hope we can working together and bring the COVID-19 under control, and more patients can be saved and saved with the appropriate use of ventilatory support.
Can I make a request to Philips that they arrange another webinar in 4 weeks' time?
Yes, we will definitely organize another second one in 4 weeks' time.
That's a great idea. From probably Joao and myself, we're at the very early stages and understanding the experience from China and Italy, and it sounds like from the UK in 4 weeks will be really valuable for us, because already I've got a number of ideas. We will be limited, as I said, at present. Most of they're planning on all the cases that require ventilation will go to our ICUs. But if it gets out of control, they will have to change those plans. And so what has been discussed today has been incredibly valuable for what we're possibly going to be experiencing over the next 3 to 4 weeks. So I think regrouping and finding out where things are would be extremely valuable for me.
I would like to sincerely thank all the speakers and panelists for your informative presentations and insightful discussion. This has been a 2-part series. If you would like to watch part 1, please click on the link below. And if you would like more information regarding Philips and the Philips respiratory care product, click on the second link below. As a trusted leader in respiratory care, Philips is vigilantly working to help inform, provide for, and empower healthcare providers, clinicians, and all those impacted by COVID-19. Because at Philips, we're committed to our mission of improving lives, and our passion is intensified in these challenging times. And now, this does conclude our session for today. Bye and take care, everyone.